Hey guys, today we're going to see about the diuretics, renal pharmacology. So before moving into that, let us look at the renal physiology. Most of you have been aware of it. So if you look at this, this is your glomerulus where you have your efferent and afferent arterioles. You have your proximal convoluted tubules. This is your proximal convoluted tubule, and you have your descending loop of Henle. You have your ascending loop of Henle. You have your distal convoluted tubules. You have your collecting tract. Fine. So if you take the glomerulus, it will filter almost 99% of the fluid which comes there. So only 1% of the fluid reaches your collecting tract, which constitutes around 1.5 liters of urine per day. So if you look at that, sodium, if you see, sodium is almost 65 to 70% of sodium is reabsorbed in your proximal convoluted tubules, and almost 25 to 30% is reabsorbed in your ascending loop of Henle, and you have around 8 to 9% in your distal convoluted tubules, and you have 1 to 2% of sodium in your collecting tract. So this is how the sodium is reabsorbed in different aspects of the nephron. So now we are going to look at the diuretics, right? As the name implies, it is mainly used to increase your excretion of your fluids. Fine. So what will happen if I do so is I am decreasing the plasma volume, and thereby I am decreasing your blood pressure. Fine. So first one, what we are going to see is your osmotic diuretics. Fine. So your osmotic diuretics. So if you look at the osmotic diuretics, it acts in your proximal convoluted tubules and your descending loop of Henle. Fine, it acts in your proximal convoluted tubules and your descending loop of Henle. See, osmotic diuretics is very simple. You don't need to memorize anything, and it works on the principle of osmosis. Fine. So if you take a look at here, fine, you have your, this is your semi-permeable membrane. This is your semi-permeable membrane, and this is your lumen, your lumen of the nephron. This is your lumen, and this is your blood, this area. Fine. So this is your lumen and this is your blood. Fine. Okay. Now what happens in osmotic diuresis is your osmotic diuresis, which includes your glycerol, your isosorbide, your mannitol, your urea. Fine. These are all your osmotic diuretics. What happens? I'm increasing your solute concentration here. So what happens when I increase the solute concentration? As a principle of osmosis, your water will move from your lower concentration to the higher concentration. So water tends to come here. So it is retained in your lumen. So what happens? More amount of fluid is it is absorbed rather than reabsorption. It is absorbed within the lumen, and it is taken and it is excreted. So osmotic diuresis works on the principle of osmotics, where your fluid move from the lower concentration to the higher concentration. So I'm adding some solutes like glycerol or mannitol or urea or isosorbate, so that I'm increasing the concentration, so the water is retained there. Fine. So if you look at the absorption, this glycerol and isosorbate is given IV, and this mannitol and urea, they are given as oral. Fine. So this is a short duration, and it is one of the weak diuretics, and it is excreted. Okay. Now the next is your loop diuretics. So your loop diuretics, which involves your furosemide. Your loop diuretics, they act in your ascending loop of Henle. Okay. So if you look at the loop diuretics, you will be very familiar of this. You have your furosemide, your bumetanide. Fine. So very similar to that, you have your semi-permeable membrane here. Fine. I'm just zooming here. Before going into this, you have your co-transporter here. Fine. What is that co-transporter? If you see, you have your sodium potassium chloride co-transporter. Fine, you have your sodium potassium chloride co-transporter. So what happens here is, I'm drawing this co-transporter here. So what happens, your sodium potassium chloride. So your sodium, your potassium, your chloride. This is your lumen. Fine, this is your blood, and this is your lumen. So normally what happens is, this co-transporter, it will transport sodium potassium chloride from the lumen to the blood, that is in this direction. Okay, so now this furosemide or bumetanide, what it does is, it is very clever. It will not attack all the three. This furosemide, it will just inhibit the chloride concentration. It will just inhibit the chloride transport. So what happens, the entire transporter is collapsed, and your sodium or your potassium or your chloride is not transported, and it is retained within the lumen, and they are excreted. Fine. So it helps in the excretion of your sodium, your potassium, your chloride, your magnesium, your calcium, all these things. If you look at the absorption of this loop diuretics, they are mainly absorbed, via 80 to 90% they are absorbed orally, and their elimination is by the proximal conveyor tubules. So if you move to the next one is your thiazide diuretics, or these loop diuretics, they are your high efficacy diuretics, and this thiazide diuretics, if you see, they are your medium efficacy diuretics. So thiazide diuretics, this thiazide diuretics, most of them would have been known. That is your, it's very easy to remember. First of all, it is your chlorothiazide or your hydrochlorothiazide. Fine, it is your chlorothiazide or your hydrochlorothiazide, and again there will be a symporter here. Fine, it is your sodium chloride symporter. Fine, this is your sodium chloride symporter. Okay, now I'm just zooming it out. So the zoomed version of it comes here. So you have your semi-permeable membrane. Fine, you have your symporter, which is nothing but your sodium chloride symporter. Fine, this is your blood, this is your lumen of the nephrons, and what happens, normally this sodium and chloride, it is transported to the blood. Okay, so this thiazide, what it does is, it will inhibit this symporter. It will inhibit this symporter, and one more thing it does is, it will increase your absorption of your magnesium. This is very important. It will increase your absorption of your magnesium. At the same time, it will inhibit your reabsorption of your sodium and chloride. Okay, and another important thing is this, the long-term use of this thiazide, what it does is, it will increase your urea reabsorption. Fine, urea reabsorption. So once the urea is increased, that will result in something called as gouty arthritis, increase in uric acid levels, that results in formation of gout, your painful joints, all those sort of things. So your thiazide diuretics, chlorothiazide and hydrochlorothiazide. Fine. Okay, now moving into the collecting duct. So collecting duct, if you see, you have your transporter, which is your sodium potassium. Your sodium is reabsorbed and your potassium is excreted. It's a very important thing. Sodium is reabsorbed and your potassium is excreted. Fine. Okay, now you have two types of drugs which act in your collecting tubules. Okay, you have your the main thing is your potassium sparing diuretics. Your potassium sparing diuretics, there are two types. First one is, it will inhibit your renal epithelial cells. Fine, it will inhibit your renal epithelial sodium channels. It's straightforward. Fine, it will inhibit your renal epithelial sodium channels, that is, they inhibit this one. Another one is your aldosterone antagonist. Aldosterone antagonist, which is nothing but your spironolactone. Fine. Your inhibit your renal epithelial sodium channel. These drugs is your amylorides, triamterene. Fine, this is amyloride and triamterene. So let us see what happens here. So as I said, you have your this is straightforward, right? Your amyloride and triamterene, what it does is it will inhibit your sodium and potassium transporter. So what does it mean? Your potassium will not be excreted. So if I stop this, the potassium will not be excreted. The reason why I'm doing this, if you can see, all your osmotic diuretics, your loop diuretics, your thiazide diuretics, all will result in your excretion of your potassium. Fine, or everything will result in excretion of potassium, which might, since potassium is very important, you cannot allow all the potassium to be excreted. So this K plus pairing diuretics is used as an adjunctive to all these diuretics, so that your potassium is spared, potassium is saved from excretion. Fine. So one type is your renal epithelial sodium channel inhibition, which is very straightforward. Another one is aldosterone. If everyone know, aldosterone is an hormone which is secreted by your cortex of the medulla. If you see here, it enters because it is a steroid. It has your receptor inside your cell. Fine. This receptor is taken to the DNA. Fine. This receptor is taken to the DNA, which synthesize your which sends signals to the mRNA, and it will result in a formation of a sodium potassium transporter. So as a result, your sodium is reabsorbed and your potassium is excreted. Fine, your sodium is reabsorbed, potassium is excreted. So what it does is, this aldosterone antagonist, so I am blocking this aldosterone. Fine, this is blocked by this. So your aldosterone does not enter, so your DNA does not send signal, so that your sodium is excreted and your potassium is reabsorbed. So the potassium is, it is absolutely saved here. So your potassium excretion is stopped by this aldosterone antagonist. I hope this is clear. This aldosterone is an hormone which sends signals to the DNA, synthase mRNA, so that your sodium is reabsorbed and your potassium is excreted. So by doing this, your potassium is excreted. So I want to stop this. So I am using something called as aldosterone antagonist, which is your spironolactone. So this is overall view. So you have your another one is very important, is that is not that much important. So your carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. Fine. Your carbonic anhydrase inhibitors, if you see, it will act on your proximal converter tubules. Fine. It will inhibit your sodium bicarbonate reabsorption. Fine. It will inhibit your sodium bicarbonate reabsorption. Fine. It will inhibit your sodium bicarbonate reabsorption. So by doing this, what it does is, your sodium is not reabsorbed and sodium is completely excreted via your collecting duct. So this carbonic anhydrase inhibitors and your osmotic diuretics, if you see, they both are your weak diuretics, and your loop diuretics is your high efficacy diuretics, and your thiazide diuretics is your low efficacy diuretics. Thiazide is your medium efficacy, and if you look at your K plus pairing diuretics, they are your two types. They are you inhibit your renal epithelial sodium channels, which is your amyloride and triamterene, and your aldosterone antagonist, which is your spironolactone. So see, pharmacology is very easy if you know the mechanism of action, and the drugs. I know it's volatile, but there's no other go. You have to remember it, and also remember where the sodium is reabsorbed more. For example, your proximal converter tubules 65 to 70%, and 25 to 30% ascending limb, and 8 to 9% in your distal converter tubules, and 1 to 2% in your collecting duct. So I hope this makes a little sense. And this carbonic anhydrase inhibitor, if you see, it is used in glaucoma patients. Fine. And there's nothing much in these two. This is weak diuretics, high efficacy, medium efficacy, and a K plus pairing diuretics. So I hope this makes sense, and thank you for watching this video. Thank you.